Well, I'm Carrie Brayman. I'm the director of the Gender Institute. I'm a professor in the English department. And many thanks for coming out on this rainy Thursday. I have the pleasure today to introduce my colleague in the School of Social Work, Gretchen Eli, who's graciously agreed to present her latest research. She's an associate professor here at UB in social work, and her scholarship focuses on vulnerable populations and their access to stigmatized aspects of reproductive health care, including contraception, abortion, and the HPV vaccine. Her work is widely published in social work and interdisciplinary health journals. Eli has most recently partnered with the National Network of Abortion Funds to conduct research on their administrative case data, resulting in the first ever published studies focused exclusively on abortion fund service recipients. And this work has been used by the NNAF for public relations advocacy and featured in popular media sources, including New York Magazine. So your work is directly connected to policy. And Eli is a fellow with the Society of Family Planning and the National Academies of Practice, and she serves as a member of IBIS, is that right? IBIS?
IBIS, I think they say, yeah.
IBIS, Reproductive Health Coalition for Abortion Access, and Reproductive Equity Research Table. So, and Eli's teaching interests include reproductive justice, and your syllabus looks amazing for that class, by the way,
Thank you.
and social welfare policy. So it's a real treat to have Professor Eli here with us today.
Thank you all. Thank you. So I do have some slides today. I'm just going to get started. I appreciate that really nice introduction. So that's the title of our talk today. And what I want to talk about, I do research on access to different types of stigmatized reproductive health care, and my most recent project is in partnership with the National Network of Abortion Funds. And one of the goals of this research is to kind of demonstrate the misery of the process of seeking an abortion and the undue burden that additional policy barriers will put on economically vulnerable women, because they are the ones who provide some funding for people when they need an abortion but they can't afford one. And so I have a colleague at Texas Christian who is also a social worker. She's the field director there and a clinical professor there, and she was the case manager for this fund for about 20 years. And so in about 2010, she started collecting the data in an electronic format so that she had this dream one day of doing research with it. And my dissertation was related to abortion patients, so she found me by, I think maybe she's the only one that ever read, the published articles for my dissertation. And so that's how we connected, and she turned this data over to me, and this was the beginning of this really interesting partnership between she and I and then the National Network of Abortion Funds. So, and my partner at NAF is named Jenny Cotting, and she is their communications director. This is the information about their mission statement, and they don't just fund abortion, they do a lot of advocacy work. They have a Repeal Hyde campaign, for example. They do a lot of work around intersections of racial and economic justice in relation to not just abortion access, but all types of reproductive health access. So they're a really great community partnership, and they also have been using this work as it builds to inform their own advocacy efforts and their public relations campaigns as well. And so it's been a really kind of grassroots community partnership between us.
Gretchen, I'm not sure everybody knows what the Hyde Amendment is.
Oh, I'm sorry. The Hyde Amendment bans funding of abortion at the federal level. So, in particular to this population, Medicaid patients who don't live in New York State or a handful of other states use state-level Medicaid funds to fund abortion. If you don't live in a state that matches with state funds, you cannot pay for an abortion through Medicaid unless there's rape, incest, or life endangerment. But those aspects of abortion need are difficult to prove. And so most of the time, when you're not in a state like New York that covers abortion through Medicaid, then you're not able to get that funding. It also impacts people like in the Peace Corps, military. People in the military can't get abortions, and no one can get an abortion in a federal hospital, federal prisoners. So the Indian Health Services, there's a lot of aspects, veteran health, all that stuff. None of that stuff can cover abortion. So all the people that are impacted by that have to pay for abortion out of pocket. So it impacts those folks, and also people that live in states where the rates of uninsured is very high. And then a lot of times, even when people have insurance, insurance policies either won't cover it or they're afraid to use it because they would be known to be someone who's seeking an abortion and they wouldn't want anybody to find out about it. There's a lot of aspects of it that are very complicated. And so what the funds do, the National Network of Abortion Funds is an umbrella of funds. There's a lot of state and maybe even local funds underneath them, so they're the umbrella organization, and they also have the Tiller Memorial Fund, which is their own fund that they started after Dr. Tiller was assassinated in memory of him, and it is a federal level fund where anybody can call in or be referred by their provider and ask for assistance to help pay for an unaffordable abortion. So we looked at almost 4,000 administrative cases from them. They just turned over these Excel files to us, and we went through. I have some doctoral students. They gave us a small stipend, and it took us about 2 years to clean the data because I couldn't devote a lot of time to it. So we went through it and picked through it and made it ready to analyze. And what I'm going to talk about today is just a representation, kind of an overview of some of the findings so far from the data analysis. And people are self-referred to this fund, or they get sent by a provider, and they don't pledge directly to the individual, it goes directly to the provider. So there's a lot of limitations here in terms of just because people got it pledged doesn't mean they were able to go through with the procedure, for example. But I'm going to talk about some of the things we do know. Parts of this came from the standardized assessment. So they have a case manager on the phone, you call in, they ask some standard questions, and they use that to try to determine levels of need because they don't have enough money to fund everyone. So if somebody's closer to the cutoff date, or they're like a young adolescent who's been assaulted, for example, they will prioritize those cases based on need. And they're always saying that at the end of the month, they don't have enough money to fund everyone. There's a monthly budget for it, so sometimes they do try to refer people to other resources within their state or region if they can't help people. And so this fund does more often fund people who are closer to the cutoff than other funds maybe at the state or local level do. And then some of the variables we got out of this were taken from the case notes. So there are paragraphs of case notes. That's one of the reasons it took so long for us to get this ready for research, because they weren't researchers, so they weren't collecting the data based on that objective. And so there's a lot of things that could have been put in the variable columns that just made it into the case notes. And so we had a couple doc students and then a lot of MSW students. Every semester, usually there's one, because I teach at the MSW program, there's 1 or 2 students that filter out to me with an interest in both research and reproductive justice, or all kinds of different reproductive health things, and they'll volunteer to do independent studies. So that's how we piece this project work together. It took a long time with the qualitative part. So here's just some information about the patients that they serve. The majority of them are between 22 and 29. That's consistent for the most part with the national. There's a database of national abortion patients that has a few demographic variables. But our sample is primarily women of color, and half of them are African American, which is different than the national database at the time that this data was collected. Those patients were primarily Caucasian, although I think that is changing. And most of them were being served in the southeastern region of the U.S., which wasn't surprising to us because of the high level of restrictions and the lack of states. Even there are no states there or surrounding states that have a state Medicaid, waiver or programs like we would in New York State. Even our funds in New York State often help people from, say, Pennsylvania, but we don't have that kind of infrastructure in the southeast. There's a lot of problems in the Midwest too. But that is behind, it was lagging behind a little bit, but it made it in a second worst place too, or the second, most places. So here's just a graph that NAF put together about the different funding distributions from this data. So you can see the Midwest is coming up behind, but it's still almost 50% of folks in the South. I'm from Tennessee, and this is not so shocking at all to me. I grew up this way, I saw this happen, and I used to work in a clinic there doing counseling for women who came in to get abortions and STD testing and different things. So a lot of this was really intuitive to me, and just for the first time there were no studies of abortion fund patients. So the Knoxville Center for Reproductive Health.
I was in Memphis.
Okay, yeah, big broad state, but yes, there's
Two abortion centers.
yeah, and I'm surprised that that's still in existence, because Tennessee has actually fared better than, say, Mississippi in terms of having resources remaining, but who knows how long that's gonna.
They can't not, because we're the only reproductive health centers, these two, in a 200 or 300 mile radius actually.
Serving
So
the other
everybody
states.
from Arkansas comes, Mississippi will leave one.
So the landscape can be both promising and dismal, I think, down there. And there were 2 clinics when I was working there in Knoxville, and now there's only one. It's been shut down. It got shut down with the wave of hospital privileges, that they couldn't get hospital privileges. And then there was a doctor who came to work when one of the other doctors died, and she had hospital privileges. She'd been working at the University of Tennessee for, I think she said 25 years, and they fired her because she was doing abortion procedures on her off time and not even getting compensated for it, because it was outside her contracts. She wasn't even taking money, and they still let her go after all that time. So the landscape down there is a little bit brutal. So here's some demographic data that I mentioned earlier. The National Network of Abortion Funds put these lovely graphs together, because when you get to mine, they're just ugly tables. So I want to make sure I get, and Jenny is the graphic artist for them, and so I want to make sure I give her credit. And then the distance traveled is increasing over time. I think this is one of the most important pieces that we found. These are already, if you remember, vulnerable women who are having difficulty funding the procedure. And I think one of the things that we're seeing that plays into the difficulty is that they're faced with this time-limited need to get this service, but they have trouble getting the funding together, which then increases the time, and then they need more funding because it gets more expensive, and it's just this awful, and I'd say there are some people that get up to the deadline and then they're, priced out or timed out of the process. And so it's important to talk about the difference between traveling 97 miles in 2010 and then almost 200 miles in 2014. That was a big contribution in terms of our finding. And there are also the people who are closer to the deadline in the second trimester, as you can see, are traveling a lot further, over 100 miles longer usually to access services, mostly because it's difficult for people to seek. Some providers don't provide services after a 12-week deadline around in there, so they have to maybe travel to Atlanta or Minneapolis or places that are, bigger cities where they have, a broader range of services. So that is what's going on with distance. And then we have hardship categories, and there's a lot of different ways that people talk about these things: burdens, reasons for seeking abortion. So we just decided to refer to them as hardships, but you can see that these at the top were the ones that we extracted from the case notes, from the qualitative pieces, and then the other ones at the bottom came directly out of the needs assessment. So they were more often asking those bottom ones on a regular basis, and then we had to go through the case notes to pull out the other ones. There are a lot of interesting things that fell out, like incarceration being a situation. A lot of people saying they just got out of jail. Medical issues too, which I don't think people think of. There are some people who terminate wanted pregnancies because of medical problems, but they still have to do the same accessing of care that everyone does. So even if you have a pregnancy that was intended and you need to terminate that, you still have to go to Atlanta if you're at a certain spot. You can't do it with your doctor usually or in a hospital, because most of the hospitals have a prohibition. So the university hospitals can't do it. It's prohibited by the state. The Catholic hospitals won't do it, and they're often the only ones in rural areas anymore. So when I was in Lexington, Kentucky, where I was at the University of Kentucky before I came here for 10 years, the only hospital that would do a termination in the Lexington region was Baptist, because they don't have a prohibition at the religious level, but it was only for things like medical anomalies and problems. They wouldn't just do an elective termination. So then you can kind of see, you know, some more in-depth of our demographics. And what I think is really interesting is that the 22 to 29-year-old range also coincides with having parenting children already. But you can see too that we have quite a bit of people that are under age 18 that are seeking these services, which was in contrast to some of the other data that showed that women like in their 30s and 40s were seeking abortion at the federal level or the national database. So we have younger, more vulnerable people in our sample compared to the sample that the CDC collects. I think it's the CDC. And again, I think the numbers of African American women receiving services is quite astounding. And this just plays into this whole thing about how people who are, you know, intersectionality of disadvantage, people are not able to access contraception or any kind of, you know, health service in their neighborhoods, and so then they end up having to seek abortion care, and then they can't pay for it, and it's just this awful web of, you know, intersecting oppression. So this is one of the things we wanted to highlight is just kind of the misery of this path that people are experiencing. If you can't get services for contraception, then this is, you know, unintended pregnancy is just kind of the next step there. And so this is turning into a situation, I think people perceive that everybody can just go get abortion services because they're legal, but that we're not, you know, we're seeing a lot of disparities for certain groups of people. And this helped us show that because we already have, everybody's here is economically disadvantaged across the board, right? So that allows us to tease out some other you know, areas where we can pinpoint where people need help. And so here's our results of the hardships. And one of the main, this was consistent with the other literature, one of the main things that we see are people are already parenting multiple children. And so they can't imagine themselves being able to have financial capacity or physical space or whatever it is to continue to, you know, add more children to their household. And so they also, this form of assistance here, you can see it. Yeah, assistance means like public welfare assistance, so that could include WIC or unemployment benefits, SNAP, which is the food stamp program, things of that nature. Again, when I see this, find it astounding that almost half the sample, or a little less than half, was receiving public assistance, which is another marker of disadvantage. And it makes me think about how when people are having to scrape all the money together for these abortion expenses, they're probably using money they would use for rent or food. And I can imagine that there's economic consequences for their families, months and even maybe years as this goes by after they have to come up with the money for this very large expense. And I will say that the fund does not fund the whole cost of the procedure. A lot of times people only get a couple $100s and they need several hundred, sometimes over $1,000 to fund. And so they are, we don't exactly know what they're doing to get the other part of the funding. I've written a couple grant proposals that haven't been funded, but NNAF is willing for me to do a project where we could contact people and follow them over time and find out how they do piece their funding together, but I haven't been able to get anyone to fund me. And so therefore, you know, we're gonna hopefully look at that sometime and make some more, be able to create some more information about it. And so you can see that a lot of folks are students. We had almost 700 students. There was people who had problems such as rape, partner violence. Some of these people had these problems at the same time. So it's not just 600 people were a student, but there was nothing else. So we'll talk about a little bit more. And here are the top reasons that people, or the barriers that they were reporting, or hardships, however you want to phrase it. These were the top ones. And so the distance was a problem for them. Lots of marginal employment. So some people were unemployed, some people were marginally employed, and that we lumped together. A lot of people were either partially housed or homeless. It was one of the first samples of abortion patients that we had been able to tease that variable out of, and then a lot of student status and people seeking for medical reasons.
And so the public assistance piece is that if they had public assistance, they were ineligible for, like, what do you mean in terms of the hardship report?
I think that they were, and this is one of the things that NNAF asked people when they call, and I think they were asking this question to try to determine levels of need. They weren't necessarily eligible or ineligible because of having that, but it was another way to demonstrate that the undue burden of this abortion cost. And so that's why they asked people if they were receiving public assistance.
So the public assistance was like, is a variable that they ask on the
Yes.
phone, but the other ones are self-reported?
They ask the ones, let's go back.
Because there could be a chance that somebody just says, oh, it's because of this, but there's actually like 8 of those things that they would, you know?
Yes, and these needs assessment ones were the ones they asked standard.
Okay.
And then these are the ones that,
So the case note ones are like the self-reported ones?
yeah, they fell out of the case notes. So we had
So
to
you could easily have somebody
extract.
who had more, it's just like it wasn't their top 3 issues.
Mhm.
It was that.
Well, we tried to pull, like if somebody had, 5 things in their case notes, we tried to just, it was like making a tick mark.
Yeah.
So we tried to put, they could be
Yeah.
counted multiple times.
Right.
Yeah,
But people could underreport their.
they could.
Issues.
And, it's
Probably do.
Probably they do.
it's gonna vary by, who your case manager is and how much time you have, and they try not to pressure people into disclosing.
Right.
And, there's a lot of very nuanced work, I guess, that behind the assessment process. So I'm sure that it wasn't as standardized as a researcher would like it to be, but it's definitely geared towards making the patient feel comfortable with their request. We tried to look at how many people were experiencing more than one barrier so that we could just get an idea of, the levels of barriers that were piling on top. So you can see here, one of the things we had to do was, they didn't record whether people had 0 children. I think it was if they didn't have any children or something about that. So we had some problems with the child variable and had to throw out some data. But for the most part, you can see that people are experiencing multiple barriers in this category of 2 to 3 or 4. There's a whole lot of people that fall into this category. So, and that doesn't mean that we, like the people that reported 0, weren't having any barriers, but for whatever reason, like you say, the limitations of the data, we don't know exactly why or why not they wouldn't disclose that. Because we, again, have to remember that we have an already disadvantaged population. It's not just a sample of abortion patients. And so the total number of hardships differed as a function of geographic location. We also looked at things like, were there more hardships in the Midwest, in states that exceeded the federal Medicaid requirements? And what that means is like New York State, where they use their state Medicaid funds to fund abortion. They will do that here. So if you exceeded, we framed it as exceeding the federal Medicaid requirements. So were there more hardships in states that just stuck with what the feds do, or more hardships in states like New York where they allowed it to be covered? And then there are even some states that restrict private insurance coverage, because we don't know which women had insurance but didn't use it or whatever, but we do know that there are states that had restrictions on it. Kentucky was one of them. And so we looked at that, and you can see here the average hardships by region. And again, the South had an average of 2.49 here, and it was the highest out of all the other geographic regions. We just used the census, how they divide up geographic regions in the U.S. to divide our geographic regions. So I think there's 5 of them. And then you can see here too, the states that do not allow for Medicaid coverage, which means that they're following the federal requirements. There was a higher average of hardships per person that was served in those areas. And then places that restrict coverage also reported higher hardships as well, or more hardships on average. It was still just around 2, but you can see there were some differences. And I just think it's harder in many ways to be a disadvantaged person living in these places, and so that's why you can see some disadvantage fleshing out in the results. So that's just an overview of the data. We have a few papers from the data. If anybody's interested in those, you can email me and I can send you copies. I think we have 4. We have one that focuses on just a general descriptive paper of the data. We have one that talks about it's called something about how far do they have to go or something like that. So it's focused a lot on distance by these different variables. And we have one about the hardships, which we just talked about here, and then one about the differences between adolescents and adults, which indicates that adolescents face more, like, for example, higher incidence of rape and less likely to have used birth control at all, and adults are more likely to have domestic violence and failure of birth control in their profile. And so if anybody's interested in having some more depth about that, you can send me an email and I can send you the papers that you are interested in. So what we have here are abortion fund patients that experience hardships across all the racial groups and all the populations that were similar to what had been shown in previous studies with general samples of abortion patients. The Guttmacher Institute does an abortion patient survey every so often. There was one in 2014. And I've actually worked with one of their data sets to look at some different things. And so they collect data from what we would call like general abortion patients. But the problems that we're seeing here are bubbling up and they're similar to what they have seen in other places. Possibly more severe, we can't tell that from this data, but it is showing. One of the reasons to talk about it like this was so that we could start to show that there is an undue burden to just abortion access in the United States in general. It's not unlike what you see in countries where abortion is illegal or restricted, like in Ireland. Now, Ireland just voted to change that, but I was working with them too, and in many ways they had a better health system and a better structure in place to get people at least to England to receive an abortion than we do to get somebody from Mississippi to Memphis. And so there's a lot of undue burden that you see that then you can make the case that policies that cause like a 2-day waiting period or something like that are really going to add a lot of problems for people that would fall into this economically disadvantaged category. So that's what we're trying to show. They have multiple hardships, and I'm a trauma person from social work, so I'm envisioning a very traumatic experience. You could become pregnant for a variety of reasons. Much of it involves unintended pregnancy can be a trauma-associated situation. Not always. Some people just end up pregnant, and that's why they seek an abortion. But there are, there's potential for trauma there, and then so then you start this journey, across wherever you are to try to access services, and you call the clinic and you find out it's going to cost you $800 or $600. You don't have that money. The funds don't give people money unless they have resources to contribute. There's this system that they use where they'll ask you, okay, so it's going to cost $500. How much do you have? And somebody might say, I have $100, and then they'll say, okay, well, you need to get $250 more, and then call us back, because they know they can't fund the whole thing, and they don't want to waste their pledges on people who are not going to meet that. And it sounds terrible. And as a social work practitioner person, it's an awful feeling to think about being on the other end of the phone and telling somebody, well, I'm not gonna give you $250 unless you can come up with $250. And so, that's kind of what's going on, and there's a lot of potential for trauma, not in the abortion itself, which people tried to say was a situation, but it's actually the experience of trying to seek the abortion where I think the trauma lies. And one of the things I was talking about, I teach a class on social action and community change, and one of the topics this week was like naming the issue, right? You have to give it a name. I think one of the reasons the women from Kavanaugh's era, of which I am one, were not able to talk about sexual assault the way Me Too women are doing now is because there wasn't adequate language to describe what was going on. I think in many of our interactions with men, we assumed that they would be predators and we would be trying to keep them at bay. And so I really want to name this experience as a potentially trauma-inducing experience, not the abortion itself, but the navigating of the experience. It's really important for me to show the potential for exacerbating any existing trauma in what people have to go to. And I think to myself, wow, how awful would it be to be faced with this timeline And then every day that goes by, the price is going up. You already don't want to be pregnant anymore, and the whole purpose of these policies is to force you to that end line where then you end up with a forced pregnancy and you can't, you haven't been able to navigate those barriers and there's nothing you can do. Which these patients here may be those people. It may be they couldn't get the funding. We don't know, or it could be that they were lucky enough to pull it all together and they did get the funding. So a lot more work needs to be done to find out like what the experiences of these people, really are, and how are they taking. I'm thinking they take out payday loans. Like there's just a lot of really terrible things that could be happening during this path to abortion that I see. So they're also already parenting children, which seems heartbreaking to me that you are faced with this economic disadvantage, and that you also know what the hardships of parenting children are, and then you need to make that decision for your own children that you have already, and that's discounted by these laws that they're putting in place. We talked a little bit about the existence of people seeking, they had welfare assistance. There was a lot of unemployment discussed in there, students, people that were sleeping on couches, and these are not situations where people would even be able to seek prenatal care, for example, even if they wanted to choose another option like adoption. There's not a stability there which would help you be able to have a healthy experience regardless of what you may or may not want to do. And like we said before, there's a lot of people traveling a long distance, and not having access to contraception was also a big barrier. And so this is always, it's happening in the context of this miserable political climate that we're in, where they just are dismantling the Title X program, which has been very solid since Nixon, I think. And the Title X program provides funding for contraception basically to anyone. You don't have to have parental consent, and these federally qualified centers receive the money to provide contraception and options counseling to people, and they're supposed to provide the options counseling in all three options. And Planned Parenthood provides the biggest amount of those Title X services, but there are independent clinics like where I used to work that also provide those services. So what the current administration is proposing, that they will not distribute Title X funds to anybody who gives abortions for a simplistic way of showing what the impacts are going to be. And Planned Parenthoods are everywhere, and a lot of people go there to get health care other than abortion. I think many of us know that abortion's only like 3% of the services they provide. So if they cut that funding to Planned Parenthood, people are not going to be able to get contraception. And as we can see in this sample, people are already having difficulty accessing contraception even with that program in place. And I think I saw a 60 Minutes episode the other night where there is a Catholic businesswoman who wants to open the equivalent of these Planned Parenthoods. Did you see this? Do you know about this? But they won't offer any birth control. They will only offer information about the rhythm method, which they call natural family planning. And it's called like
those crisis pregnancy places.
But they're going to have real doctors and nurses in there that will provide prenatal care all the way up until delivery, and like STD testing and breast exams and cervical cancer screens and that whole business, but they won't offer any contraception for people. And it's called like Orvis or something. This is new to me. See, there's so much information that I'm always taking in. I'm not sure how long this has been going on, but her mission is to replace Planned Parenthood basically with these clinics that will no longer, it'll offer everything. And see, when you're a vulnerable, disadvantaged person in a medically underserved area, you will not know, most likely, that those services are restricted until you end up in the clinic, and then you realize this is my only provider. So we're seeing a lot of desperation, I think, in terms of accessing contraception, and when Title X, if it is rolled back, then things are going to get really ugly here. So these findings also support about patients in the South and Midwest having the greatest number of hardships, which we talked about a little bit before, and also states that don't use Medicaid dollars to expand abortion access. And it's also true for patients from states that restrict, which I mentioned earlier. And I talked a little bit about trauma. So this Mackenzie Moore article talks about, in relation to homelessness, like a politicized approach to trauma-informed care. And I think it should be applied to the abortion-seeking experience as well, which is what I mentioned before. Like, it needs to be named as trauma causing. It needs to be separate from the process of getting the abortion. There's a lot of dehumanizing that goes on and stigmatizing, and so I'm imagining that the people who actually end up getting an abortion, they have some really great coping skills. They jump through a lot of hoops to get abortions because they know that's what they need to do or want to do. And I'm imagining there's a lot of people who their coping skills are not good enough, and so you're seeing people then are forced into parenting because they were not able to navigate all these barriers. And I think that's pretty distressing, and in 2018 it just doesn't seem to fit with what a human rights perspective should be. I just advocate for applying principles of trauma-informed care to the design of policy around reproductive health and also distributing contraception in general. Women in places like Nepal are willing to risk their lives to terminate a pregnancy. I think women everywhere feel that way. When they want to terminate a pregnancy, they know that's what they want to do, and they'll do anything, as people did, before Roe here. They went to Mexico and all these places, and a lot of people died, and that's why you saw such broad support of making it safe and legal, because people were dying. And I remember my gynecologist in Knoxville when I was young had said that she learned to do hysterectomies from her mentor, who had done so many on women who had botched abortions. And so that is something, though, that's not a part of our common experience anymore. I am a legal abortion. I came of age during legal abortion, but my mother didn't. And so she certainly can recount stories. There's some hope in terms of medical abortion and being able to self-manage that, but I just don't see why in a country with an advanced medical system that people should have to take a pill at home and then just just wait and see if they have a complication, because it's rare, but it can happen, and there's no reason why you shouldn't be able to have a medically supervised abortion in the United States. So we have to think a lot about what this is going to do. So as I had said before, this is the research so far is just showing that these patients are really experiencing a wide range of hardships that are potentially could be causing trauma to them. If you use a definition of trauma that's really clinical, it wouldn't be a trauma-causing experience, but it would cause traumatic stress that can contribute to trauma, if that makes sense. So we're not saying that the trauma itself can be caused, but if you're a trauma-exposed person, then it has every chance of re-traumatizing you over and over again as you have to jump through all these hoops. So that's just kind of my concluding statement, and then if you all want to have a little time for discussion, we can talk. So, yes.
I love the framing it as an undue burden, because legally that's our standard now.
Mm-hmm.
So I think what's so interesting about this is, it's something when you read about it, when you read Casey, but how different what an undue burden is to somebody is so subjective.
Mm-hmm.
To somebody who is a rape survivor who has found herself pregnant, a transvaginal ultrasound could be a trauma-inducing experience. Or, we've gone from this is an objectively constitutional right to now we have this sliding scale of what we consider an undue burden.
Mm-hmm.
And it's so clear for so many people that an undue burden would be to so many people like such a minor thing, coming up with $400 for a medical abortion is an undue burden for a great chunk of the country. So when the courts are talking about an undue burden being like trap laws or admitting privileges or things like that, that's such a high level of what's the point of even talking about that if we can't even recognize that for a great majority of people who are trying to make a responsible choice, $400 is undue burden. I like that framing. When you said to name something, I like the idea of naming it around that language, because that's the language of the courts.
That's a great point from a legal standpoint. And we just want to show that it is a burden.
Or a waiting period. imagine if you had to go 175 miles and you had a 24-hour waiting period.
Or
You need 2 nights in a
72
hotel.
hour.
Yeah, you need 2 nights in a hotel, you need this, you need that, I mean.
Oh, people sleep in their cars in the parking lots.
We get them, I'm involved with the Planned Parenthood here, and we're opening our new surgical suite close to the throughway because we have so many people coming from Pennsylvania. That moving from Niagara Falls to Depew is gonna make such a difference for our patients that is worth it to us, you know. I mean, not to mention just people coming from Buffalo going to Niagara Falls and stuff, but I like the undue burden language is so important.
And thank you for saying that, because I have been doing a little bit of work with the ACLU to try to think of ways to frame it that say the same exact thing but don't disadvantage them when they're using information in cases. Because what I had a consultation, and she said a lot of the work that you all, and this is a small community of researchers, but a lot of the work that comes out will have these weird phrases in it that researchers use that the counter case can pick on, and you know, so we're trying to do a better job of working with them to make sure our language is smoother, because we're siloed, and so we're trying to collaborate with them a little bit better, and also it's and I think it's important to call it what it is, like you're saying, because it truly is.
But undue is just so subjective. Like, undue to me is not the same as undue.
Well, I mean, I have a credit card, so I could get an abortion and
Yeah.
pay for anyone's almost any time if I had to fly to Sweden, whatever. But people don't have access to credit. I mean, I just don't think that average people realize the disadvantage that we have in front of us. I do think that Hyde was fully intended to disadvantage poor women. He even said that. When he proposed it, he said, I can't stop abortion for everyone, but I'm going to do it for poor women because that's the only people I have control over. Something, there's a quote from him. So it's definitely, there are people who realize that they're, only disadvantaging a certain amount of people, but it's definitely an undue burden.
I think that, some of what Kate Mann's trying to do and the Rebecca Taster who's doing the work around women in anger, I think that because of the time we're in, that placing this within the context of why are we even talking about this, right? When you started off and you said contested reproductive practices, or what was the
Stigmatized
Stigmatized.
aspects of reproductive health.
Every aspect is. Contraception is, right? So, to me, when you laid out the framework at the beginning, it just looked like a map of what it means that we live in this system of male supremacy. That's the context within which women are doing all this stuff. And so there's the undue burden, but there's also like a system of, whatever the opposite of male supremacy is. And that means that there's lack of access because there's no doctors who can do it. There's, a different law every few months that restricts access. There's, anyway, so I think it needs to be put in that bigger context, sort of like Kamala Harris saying to Kavanaugh, can you think of any laws that give government the power to make decisions about the male body, right? Like, that's the framework. So, and then the other part so in terms of how you might frame it, then the other piece about language is, I think that right now, using all the trauma-informed language that we use is not helping us, because people react to, it's absolutely true, but people react to that word, and then they say, oh, everything, right. So I think we have to be really clear about, the undue burden of, like time, money, distance, tracking the stuff about how many contacts with the medical system, those kinds of things, to speak about it in plain language, because the other stuff just people shut down. And they could be allies as well as not allies. And then it gives other people more things to latch on to and say, oh, it's just those politically correct blah, 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 as opposed to the fact this is outrageous. Right? For all these are, I mean, I'm a public health person, so it's like these are health issues, but they're women's health issues, and therefore they've been politicized, controlled, etc. And you know, that's the framework. It's like Linda Gordon's book in the 1970s, Woman's Body was Women's Right. It's, you know.
I know. Has there been progress? I don't know, it's just so depressing. I'm just thinking that the border between the U.S. and Canada is becoming more and more pronounced, in the sense that the U.S. is looking more like Argentina and Latin American countries that are banning abortion and have banned abortion, where Canada and Europe, and now with Ireland's recent referendum, it's going in the opposite direction very clearly and has been for a very long time. So the stigmatization showing this to how the U.S. has been aligning itself more with the Southern Hemisphere in terms of these very kind of traditional Catholic views of women's bodies. But also I was thinking, and this is a different related point, I don't know how many of you saw Angie Thomas here, the young adult writer for the Humanities Festival. She wrote a book called The Hate You Give. And she said, The Hate You Give is from Tupac, and it's about, you know, racialized violence in Mississippi and all that. But her next book is about poverty as trauma. And I'm just thinking it was just so interesting and important to see reproductive justice as part, or injustice as part of that traumatic experience, for how poverty is gendered and how unevenly that's experienced too. And I was wondering if you were planning to interview the tiller workers who are answering the phones and having to say, well, you need matching funds day in and day out. Have you thought of thinking about trauma in terms of their work experience, having to be in the trenches of this?
You know, I think that's a great question. And the problem, of course, I run into is I haven't got a funding source for any of this work. So I'm situated in this gendered system where you're supposed to bring in grant funds to fund your work. But they are open to that. The funds are small. So usually they have one or two people. Like my colleague at Texas Christian did it for 20 years. I think she was the only one. She took all the calls. And she did it on her own time. On the weekends, and just kind of had fun with her. The fund has grown a lot since then. It was called something else before it was named the Tiller Fund. It hasn't been the Tiller Fund for 20 years. But I think there's a lot of work that could be done with how do the people working there react to the stigmatized situation that they're in. And there is some work that has been done, but having to tell people things like, a practitioner having to tell people things like, you need to get $250 more and call me back, that can't weigh on you well after a long period of time. And I think that's important to find out about what their perspectives are.
I wonder if it's similar to the defense mechanisms that the providers build up. When I worked as an abortion doula, I noticed that particularly the doctors, they went through a routine of commentary that for an outsider or a bystander was, you couldn't believe it. I mean, you got offended immediately. It's like, you have to stop moving. If you continue moving, if you continue twitching, you can't get the procedure. And you know, it's understandable. I'm getting really mad because I remember this old white doctor, you know, but he was the only one who would provide it. Saying that to a patient, and the patients were vomiting and they were, you know, and completely in distress. But it seemed that he was so in this routine of going through that just to, in the end, make it easier or faster so that he could get through another patient quicker, so he wouldn't have to send away 3 more women that day. That becomes some kind of narrative that you are part of to shield yourself, but also to have an end goal that is better for more women, you know? So I don't know if you're ever able to even access that bubble, if you're able to recognize that it is there. I don't know.
You know, that's a really good point, because I'm doing a talk in New York City at the Planned Parenthood. They have a national meeting that they call an abortion school. And so they try to send 3 people from all of their regional offices, like a clinician and a front desk person, and then maybe a mid-level person to talk about different things, is how it's been explained to me. And one of the things she wanted me to come and talk about was the stressful and traumatizing aspects of the abortion experience, because something that I know from being a provider and have heard from people is that there's kind of this attitude about any abortion is good enough in the provider community, because they're under so much stress and there is so much stigma around the job that we've seen stories of people. I was analyzing this data from the Tennessee abortion stories, and there was this narrative in there about the front desk person licking this lollipop in this really casual way, and then the doctor had one too, and he was saying, oh, these are really good, did anybody offer you one? And this is a really callous attitude towards something that for the individual patient is very heightened, even if it's not traumatizing necessarily. And so I wonder if that's an aspect of coping that is turning into, and I've talked to many abortion doulas who have this, kind of same, I go in and try to make this process a little more smooth, and I'm a little bit taken aback by the things that people say and some of the reactions of the providers, but they're there every day dealing with this, and so they've just become kind of dead to it, I think. So I believe there's a lot of interesting work that could be done there. It's not a favorite of, I've had a lot of pushback from journals about the way that things are framed. They definitely do not want to hear any negativity about the providers. Mm-hmm. So I tried to get that article about the Tennessee abortion stories published with the lollipop story in it, and I had to take it out.
Wow.
Because they don't want any more negativity around what's already so polarized. And I think that's a really interesting thing there too, because we've got to be open about what people's experiences are, regardless of what, kind of the fallout is. So,
Have you thought of interviewing Dr. Willie Parker in Mississippi?
some people know him. I haven't ever talked to him, but I would love to meet him. So I'm very appreciative of him and his work. And I just thank you for your interest in the topic, and if you have other questions, just send me an email. Thanks for coming.
Thank you so
Thank you.
much.